विश्वात्मके आता विश्वात्मके देवे येणे वाग्यज्ञे तोषावे तोषो निमजद्यावे पसाय दानहे जेखळांची व्यंकटी सांडो तया सत्कर्मी रती वाढो भूता परस्परे पडो मैत्र जीवांचे दुरिताचे तिमिर जावो विश्वस्वधर्म सूर्ये पाहो जो जे वांछिन तो ते लाहो प्राणी जात वर्षत सकळ मंगळी ईश्वर निष्ठांची मांदियाळी अनवरत भूमंडळी भेटतु भूता चला कल्पतरूंचे आरव चेतना चिंतामणींचे गाव बोलते जे अर्णव पीयूषाचे चंद्रमेजे अलांछन मार्तंड जे तापहीन ते सर्वाही सदा सज्जन सोय रे होतु किंबहुना सर्व सुखी पूर्ण होऊनी तिन्ही लोकी भजिजो आदि पुरुखी अखंडित आणि ग्रंथोपजीविये विशेषी लोकीये दृष्टादृष्ट विजये हो आवेजी येथ म्हणे श्री विश्वेश्वराव हा होईल दान पसावो येणे वरे ज्ञान देवो सुखिया झाला.
So thank you. On behalf of Department of Emergency Medicine, in pursuing excellence over a period of 11 years, so this year we have MCAM 24. We are organized as a different like case-based learning for 3 hours, and it is not an attempt of, it is a teamwork. And what we see, this was a regional meet in Mumbai, Navi Mumbai, Thane, and even suburban Mumbai. Everyone has been registered, so some of them they will be coming late. So at present it's my pleasure duty to welcome, I would like to welcome the external members like Dr. Nitin Jagasias. Sir, I request Dr. Sagar to welcome Dr. Nitin. Nitin is the professor and head of Department of Emergency Medicine and Apollo Hospital. They are running a DNB emergency medicine program. I would like to request Dr. Kunju Lakshmi to welcome Dr. Varnika. I request Dr. Sib to welcome Dr. Prasad Tushayu. Prasad is the EM HOD at Okat Bahindar Hospital, and Varnika is a associate consultant as well as the faculty member at the emergency medicine department at Reliance Foundation Hospital, our own alumni. Then I request one of the our residents, yes, yeah, Dr. Akshay, to welcome Dr. Sushil Kumar sir. No, sir. It's our yeah. I request Dr. Pratik to welcome Dr. Jayashree Ganekar madam. Yeah. I request Dr. Varun, SR in Emergency Medicine, to welcome Dr. Vijay Kamale. At the same time, I recognize presence of our professor, sir. I would like to recognize Dr. Rahul Taksande, sir, Professor IHBT at our hospital. Then our own Professor of Emergency Medicine, Dr. Khatija Jumkawala, madam. Then we have Dr. Rakesh Thamke, Professor and Head of Family Medicine, in charge Professor and Head of Family Medicine. Dr. Aditi Singhania, madam is also there. I think, yes, I would like to recognize your presence. Then at the same time, we have our Amit Pinjari, who is the Assistant Professor of EM. He is looking after night, but you may see, because today I am very happy that he is there with us. So, with this formal welcome, I extend my heartfelt thanks, gratitude for you, for a CME, which is case-based learning. And then I request to start the next case-based learning. As a first, I request SIP to take over. Thank you.
Thank you for that wonderful speech, sir. That was the formal introduction. Now we have finally gotten into business. For the pilot case, I request Dr. Rochelle Colasso, second year postgraduate from the Department of Emergency Medicine, MGMIHS, to present a case on dilated cardiomyopathy. I would request Dr. Vijay Kamale, Professor and Head of the Department of Pediatrics, to preside over the case discussion to follow after the presentation. Over to you, Rochelle. Also, Dr. Nitin Chagasya, Professor and Head, Department of Emergency Medicine, Apollo, to preside over the case discussion to follow.
Good morning, everyone. I'll be presenting a case. The case capsule is a 2-month-year-old female. She was referred from outside hospital to MGMER with the complaints of cough since 3 days, difficulty in breathing since 3 days, and excessive crying since 1 day. On examination in the ER, airway was patent, no pooling of secretions, no gurgling sounds. Breathing, RR was 58 per minute, SpO2 98% on 4 liters per minute of oxygen via nasal prongs. Bilateral air entry was present. Bilateral basilar crepitations were present. Chest retractions were absent. For this, we started the patient on oxygen via simple face mask. Chest X-ray and ABG was ordered. Circulation, heart rate of 200 per minute. BP 88 by 51 millimeters of mercury. CRT less than 2 seconds. Peripheral pulses were felt. Peripheries were warm. IV line was secured. Disability, GCS was 15 by 15. RBS 117. Pupils bilaterally reactive to light. Exposure, no hypothermia. On reassessment, because of increased work of breathing, patient was put on HFNC with a flow of 8 liters per minute at an FiO2 of 50%. ER adjuncts, chest X-ray was done. As you can see, there is no patch of consolidation. However, it was a AP view, hence it may be a query cardiomegaly according to the X-ray. ECG was showing sinus tachycardia. ABG done was showing a pH of 7.58, PCO2 of 27, PO2 of 208, lactate of 2.4, bicarbonate of 28.1. It was suggestive of a respiratory alkalosis with metabolic acidosis. 2D echo was done, which was showing an EF of less than 50%. Sinus tachycardia was seen during the study, global hypokinesia, and no RWML. Ample history, no known allergies, not on any regular medications. Patient was vaccinated till date. No history of any previous admissions. Patient's sibling had a similar complaint at the age of 2 years and had died 1 year back. Last meal today morning. Yeah. History of presenting illness. Patient was apparently well till 2 months of age when she developed non-productive cough 3 days back. Symptomatic treatment was given outside. However, there was no recovery that was seen. And patient relatives noticed that yesterday night, the patient was having excessive crying. Hence, they had taken him to the outside hospital where basic management was done and the patient was then referred to MGM. No history of fever or vomiting, no history of cyanosis, no history of reduced fluid intake. General physical examination, patient was conscious, sick looking, non-irritable, afebrile, no pallor, icterus, cyanosis or pedal edema, no signs of dehydration. Systemic examination, respiratory system, bilateral air entry was present, bilateral basilar crepitations were seen, no chest retractions. Cardiovascular system, S1 and S2 HELLP, S3 gallop present, per abdomen soft and non-tender, central nervous system, child was active, moving all 4 limbs. Outside blood investigations was sent, which was suggestive of elevated CRP was 1.96, D-dimer 8.13, elevated TROP-T 613, CPKMB 28.99, BNP was more than 30,000, creatinine 0.96, urea 24.9, HB of 7.9, total count of 16,000, differential of 51 neutrophils, 45 lymphocytes, 2 eosinophils, 2 basophils, platelets of 2,61,000, SGOT of 100.4 and SGPD of 69.7. Samples that were sent from our MGMER, CBC, cardiac markers, BNP, RFT with electrolytes. The treatment that was given in the ER was patient was started on inotropic support, that is Melurone, 0.5 mcg per kg per minute. Diuretics was started, injection Lasix. Fluid restriction was done, and antibiotic of injections Eftriaxone was given. The patient was given a working diagnosis as a 2-year-old child, came with complaints of breathlessness, was diagnosed with respiratory distress, secondary to heart failure with reduced ejection fraction with cardiogenic shock. On disposition, patient was given a pediatric reference, a cardiology reference, and shifted to PICU. In PICU, cardiology reference done, 2D echo was done, which was showing dilated cardiomyopathy, query dilated post-viral, grade 2 mitral regurgitation, trivial aortic regurgitation, trivial tricuspid regurgitation, grossly dilated LV, poor LV systolic function with an EF of 20 to 25%, and mild pulmonary arterial hypertension. USG abdopelvis was done, which was no significant abnormalities were detected. On the opinion of the cardiologist, IVIG was started based on the diagnosis of query viral myocarditis. During the course of stay in the PICU, patient's inotropic support was reduced, the HFNC was tapered, and child was started on full oral supports, after which the patient was shifted to the ward. Now, why this case is being discussed? What we do for most of our patients, we start them on, let's say we start them on oxygen via nasal prongs, then face mask, then we go forward to NRM. But then we always skip on and then we go to an NIV or intubation. HFNC is something that we do not use a lot. So in this case, since HFNC was used as an intermediate to prevent the, to at least try not to intubate the child, that is the reason why I have presented this case. Let's talk a little bit about high flow nasal cannula. It is a delivery system with a flow rate of 2 to 100 per minute. It provides high inspiratory flow, provides more accurately delivered FiO2, and reduces the inspiratory resistance. Many of these devices can also provide a small amount of PEEP, from 2 to 5 centimeters of water, and it helps reducing dyspnea. The first table that you can see on the right hand side that shows that up to what liters of flow rates can be given in each age group. As you can see, neonates you can give up to 8 liters per minute. From 0 to 12 kgs you can give 2 liters per kg per minute up to a maximum of 25 liters per minute. From 13 to 15 kgs, 2 liters per kg per minute up to a maximum of 30 liters per minute. 16 to 30 kgs, 35 to 40 liters per minute. 31 to 50 kgs, 40 to 50 liters per minute, and a more than 50 kg adult, you can give up to 40 to 70 liters per minute. About the contraindications of HFNC, it is unable to protect the airway, life-threatening hypoxia, base of skull fractures, multifacial fractures, recent upper respiratory surgeries, nasal obstructions, severe oropharyngeal mucositis, and epistaxis. Conditions which warrant careful HFNC is severe agitation, unable to follow commands, respiratory acidosis, severe swallowing impairment, recent neurosurgery or upper gastrointestinal surgery, poor skin integrity of face, that is in burns. Specific additional contraindications of HFNC in children is choanal atresia, certain craniofacial malformations, severe central apnea, transesophageal fistula, pre and post-op. Specific additional conditions which warrant careful HFNC use in infants and children, bulbar dysfunction and neuromuscular hypoxia. This flow chart so as you can see, in acute hypoxemia or respiratory failure, HFNC can be used in patients where no impaired consciousness or persistent shock is seen. If you're starting the patient of HFNC, then you have to monitor the patient regularly, for which you can use the ROSC index, which you can see. It calculates the SpO2, FiO2, and the respiratory rate. And if anywhere during the course the ROSC is less than 3.85, that is when you have to intubate the patient. And with regular monitoring, you can actually take the patients off HFNC and start them on low flow oxygen supplies like NRM or normal face mask. HFNC has increased use in critical and acute care settings to deliver respiratory support in all patients of all age groups. They are easy to set up and use and well tolerated by patients and have few reported adverse effects. More research is required investigating optimal settings for HFNC initiation, maintenance and weaning for specific etiologies of respiratory failure in mind. Thank you.
Dr. Vijay Kamale, Professor and Head, Department of Pediatrics, to share his insights and thoughts on the case.
Nice presentation related to dilated cardiomyopathy and HFNs. Actually, here we are having all this facility immediately in EMS, so we can use it. But I will go just first part clinically. When this child has come to you with relatively stable GCS, not much. Only problem looking also clinically was more of cardiac rather than because respiratory distress was not there. 58 is actually not respiratory distress for a child for 2 months. That is not respiratory distress, to be frank. So okay, but that means if no respiratory distress and some problem is there, some other cause other than respiratory cause should be found out. That was the clinical thing you have done. So you have done X-ray chest, showed cardiomegaly, and then investigated based on that thing. So child had anemia also 7.9 thing. Although that also 2 months can be little bit go towards physiological anemia of infancy. That also is not worry as far as the thing. Although child was anemia has to be treated or taken into consideration later on. When 2 months come with some history of one previous death, then some genetic factors also has to be considered. Probably sometimes can be in the form of storage disorders also, or some other genetic, because there are a lot of genetics related to dilated cardiomyopathy. So that should have been consider
the-
later on, so I don't know whether
Sir,
it
the
was done.
genomic sequence for the
Was
patient was sent. Yes, sir.
sent.
Yes, sir.
So the report is still awaited. I think not yet come.
Yes.
So it will take, it takes little. So probably genetic cause based on history only you have to find out with the in consultation with that you have done pediatric residents. So afterwards it was the case was very well base managed according to EMS protocol. No issues regarding that. HFNC we are using commonly now because it is less invasive, and till definitely you want to intubate till that time as a tidal over crisis we are using, not as a 100% sure way of maintaining the airway. But this case was having cardiac rather than airway problem, so HFNC can be done, can be. Okay, thank you.
So yeah, I think a couple of points from my side. Sir rightly pointed out respiratory distress was not there. Were you all getting distress looking at the case? Or was it just me? 2-month-old with that respiratory rate, I think we'll be in more distress than the kid. So that is one thing I'd like to highlight is quite often we start treating or giving things out of pressure on us rather than what the patient needs. So I think sir brought that out very well, that for normal physiology at that stage do we actually need to give. And second point with HFNC, definitely there's a huge role which we are missing out in this country. COVID actually brought it to us, lot of positive findings with HFNC. Like anything in medicine, it's selection of cases. So like Rochelle has also brought out that it's not a definitive airway, it's not where your airway is compromised, your patient has to be conscious. But type 1 respiratory failure, please remember, type 1 respiratory failure, we all jump to NIV over here. There's a role of HFNC, there's a huge role of HFNC. We need to be guided by pulmonology, by intensive care team for sure. But we need to look at it in a more, I think more often than we are at the moment. And I think we'll find that it will play a certain role in certain respiratory conditions for type 1 respiratory failure. That's it. Thank you.
One good thing about HFNC, it gives certain amount of PEEP that is very, very essential for a newborn or some till 1 year of age. So that PEEP has to be there. Otherwise, it is basically pressure support.
Question for Dr. Vijay. Since it was like one of the sibling had died, so what will be the outcome for these patients? What will be the definitive?
That is why genomic studies has been done. But in India, actually, it is even if they get something, we have to send the child for cardiac transplantation. So that is the only thing. In fact, we have tried once such a child, but it is very cost prohibitive thing. So, but can be done if patient is affordable.
That reminds a story. One of the child who was waiting here in India for a cardiac transplant by Dr. Mule sir, we have highlighted here only. So the child was waiting, and there was one trauma child of the same has undergone the trauma transplant, the cardiac transplant that time. So it is one of the established procedure nowadays. So definitive treatment for this patient can be a cardiac, cardiac transplant. Yes, yes. It is in India, but nowadays we do not have to worry. And if at all, what will be the rescue procedure? If at all, if your child is waiting for the procedure in assisted devices in a pediatric age group,
It will be ECMO, I think. From this kind of, when it's a cardiac, I think ECMO facility, again access in a 2-month-old, lots of challenges, but ECMO would be something to hold on. But then you don't know when the heart is coming, right? So it's how long do you hold on? So it's a very challenging.
okay. So no role of assisted devices in a pediatric age group. So for the message is like the definitive is a cardiac transplant.
Thank you.
Since we have head of the departments of both pediatrics and emergency medicine, I'm sure some of the residents would want to make the most of it by shooting some questions, clarify your thoughts. Anybody, any doubts? Anybody? Anyone input, feedback, doubts, anything? I think, yeah, that was the case. Thank you so much, sir, for sharing your thought and idea on the case. I'm sure this case would make a positive impact on the lives of those we serve.
Yeah, I recognize the presence of Dr. Sanjay Doke sir, Professor and Head of Traumatology.
Let me me request Assistant Professor Dr. Sagar Sinha and Dr. Busare sir to hand over a bouquet as a token of gratitude to Dr. Doke, Head of the Department of Traumatology.
Welcome the presence of Dr. Sunila Madam, Professor of Preventive and Social Medicine. I request Sagar to welcome Madam. Yeah, thank you.
Thank you, Rochelle, for the presentation. Next, we have Dr. Mandar Deshpande, second year postgraduate from our department, to present a case on oral hypoglycemic agents induced hypoglycemia. I kindly request Head of the Department General Medicine, Dr. Jayashree Ganekar, to preside over the case discussion to follow after the presentation. Over to you, Mandar. I would also request Dr. Tushayu Prasad, Head of the Department of Emergency Medicine, Wokat Hospital, to also preside over the case discussion to follow after the presentation.
Good morning all. My case is that we had a 59-year-old male who was brought to the ER with complaints of decreased responsiveness for 4 to 6 hours, vomiting episodes since 5 to 6 days, giddiness since 5 to 6 days, loss of balance since 5 to 6 days. The patient was immediately triaged as red and connected to the cardiac monitors. Random blood sugar was done immediately for the patient, which was 35 milligram per deciliter. Immediately a large bore IV access was secured and dextrose 25% was given to the patient. The airway was assessed. The airway was at risk. The patient was not able to phonate, so an oropharyngeal airway was secured for the patient. There were no pooling of secretions or no foreign bodies. On breathing, the RR was 24 per minute. SpO2 was 96% on room air. Bilateral symmetrical chest rise was seen. There was no use of accessory muscles of respiration. No dilated neck veins. Normal vesicular breath sounds were heard over all lung fields. In the circulation, the capillary refill time was less than 3 seconds. The BP was 90 by 60 millimeters of mercury. Heart sounds were heard and peripheries were warm. The interventions done at this point were that another wide bore IV access was secured and IVF crystalloid bolus was followed by maintenance at 100 cc per hour. Currently, the GCS was E1, V2, M5. Pupils were bilateral reactive to light. There were no lateralizing signs. And following the dextrose 25 injection, the RBS improved to 90 milligram per deciliter. Hypothermia was prevented and there were no external wounds, injuries or bruises seen. Adjuncts which were done were the random blood sugar, the blood gases which were done suggestive of a pH of 7.51, a PCO2 of 28, lactates of 1.2 and a bicarbonate of 26. The ECG done was suggestive of a normal sinus rhythm. Post-correction of the hypoglycemia, we reassessed the primary survey in which the patient was able to phonate and complete sentences. There were no pooling of secretions and no gurgling sound, so we removed the OPA. Disability, the GCS improved to E4, V5, M6 and the patient became symptomatically better. The patient denied any allergies. He was a known case of type 2 diabetes on tablet glimepiride and tablet metformin. He was also a known case of hypertension on tablet amlodipine. His past medical history included a type 2 diabetes since 4 years, hypertension since 4 years. He had an episode of cerebrovascular accident 6 months ago and a known case of chronic kidney disease. Patient was apparently alright 5 to 6 days ago when he started experiencing vomiting, multiple episodes, non-projectile, non-bilious, containing food particles associated with reduced appetite. Patient also had episodes of giddiness. The patient relatives also noticed loss of balance and difficulty in walking, and he had decreased responsiveness, following which he was brought to the ER. The patient did not give any history of fever, headache or night sweats. There was no history of palpitation, sweating or convulsions. So in general examination, the patient was conscious, oriented to time, place, person. The pulse rate was 98. Blood pressure was 90 by 60, which improved after fluid resuscitation to 110 by 70. Respiratory rate was 24 cycles per minute. The SpO2 was 96% on room air. There was no pallor, edema, lymphadenopathy, icterus, cyanosis or clubbing, but dehydration was present. On systemic examination, the patient was conscious, oriented to time, place, person. Higher mental functions were normal, the cranial nerves were normal, and the sensory examination was also normal. The tone was increased in all four limbs, and the plantars in the right leg was mute and downgoing in the left leg. Heart sounds were present. Abdomen was soft and air entry was present bilaterally. Additional investigations which were done were complete blood count, urine routine, electrolytes, and HbA1c. So this was a 59-year-old male with complaints of decreased responsiveness, vomiting, giddiness, loss of balance in a known case of type 2 diabetes with hypertension, chronic kidney disease, with past history of old ischemic cerebrovascular accident, which was diagnosed as a case of acute encephalopathy secondary to hypoglycemia. In this case, the Whipple's triad of hypoglycemia was satisfied, which included hypoglycemic symptoms, a blood glucose level less than 50 milligram per deciliter, and a symptomatic relief which was obtained post the administration of glucose. So following initial resus and stabilization, the patient was downtriaged from red to yellow. All of the oral hypoglycemic agents were stopped. The random blood sugar was holding at 90 milligram per deciliter at the time of disposition, and the patient was admitted in the high dependency unit. Post 8 hours of admission in the HDU, the patient again had hypoglycemia, which failed to improve in spite of multiple administration of glucose solution, and the RBS continued to be low. The patient was then shifted to ICU for further management. In the ICU, the RBS levels, the random blood sugar levels were optimized by continuous glucose administration. However, the sensorium continued to be low. The patient was then intubated and mechanically ventilated for airway protection. And to investigate further the low sensorium in spite of the optimal RBS levels, an NCCT brain was done which did not show any intracranial pathologies. Lumbar puncture and EEG were also normal. Following neurological consultation, the case of acute encephalopathy was attributed to hypoglycemia. An incidental finding which we found in this case was a ping-pong gaze, which is an intriguing rare neurological phenomenon characterized by rhythmic oscillation of the eyes, which has been documented in isolated case reports within the medical literature. This sign usually denotes extensive bilateral hemispheric involvement. So this was the case. The patient, there were random oscillating movements of the eyes to and fro. So while coming to discuss hypoglycemia in the ED, if we have a conscious patient, we can give him per-oral administration of glucose. If we have a patient with altered sensorium, we can give him 50% dextrose in water as an IV bolus, which provides about 25 grams of glucose. So when blood sugar reaches 70 milligram per deciliter and the patient regains consciousness, we can continue carbohydrates to prevent the recurrence of hypoglycemia. So if blood glucose normalizes but the patient still remains unconscious, what we can do is we can give a continuous infusion of IV dextrose, this 5% dextrose in water at a rate to maintain the serum glucose above 100 or to achieve euglycemia. We have to check blood sugar every 30 minutes for the first 2 hours and look for a rebound hypoglycemia. If hyperglycemia is maintained by slow administration of dextrose, the infusion may be reduced and we can eventually stop it. The hypoglycemia resulting from sulfonylureas is much more challenging than insulin-induced hypoglycemias. If all these measures, including glucose administration, does not work, what we can try is glucagon, which is an alternative, which can be given subcutaneously or intramuscularly in the absence of an IV access. In adults, glucagon is administered at a dose of 1 milligram as a subcut or an intramuscular injection. If glucagon is not available, we can also use octreotide. It is recommended after initial glucose therapy has been initiated for sulfonylurea-induced hypoglycemia and can be considered when the response to dextrose is inadequate. It is primarily used to reduce the risk of recurrent hypoglycemia. The recommendations vary from a single 50 to 100 mcg subcut injection after a single hypoglycemic episode to serial subcutaneous injections or a constant IV infusion after a second hypoglycemic episode. Another drug that we can use is diazoxide, which can be used in the treatment of refractory sulfonylurea-induced hypoglycemia. It acts by directly inhibiting the insulin secretion from the pancreatic beta cells. Patients who experience hypoglycemia due to sulfonylureas, non-short-acting insulin or meglitinide should be admitted for serial glucose monitoring and treatment. So, as a final message here, is that we should always consider hypoglycemia as a potential cause for altered mental status. As the patient comes in with altered mental status, we usually tend to think about a stroke or a meningitis, but this is a potential reversible cause which can be treated in the ED and managed there and then itself. So hypoglycemia is a reversible cause and should be immediately identified and treated. The failure to determine this blood glucose level early and subsequently treat it can result in a delayed or misdiagnosis, which can be associated with morbidity because of CNS injury or unnecessary invasive procedures and therapies. So rigorous monitoring of glucose in such cases with altered mental status and who are diagnosed with hypoglycemia on OHS should be done so that potential complications and such invasive procedures as a patient being intubated, mechanically ventilated can be easily avoided. Thank you.
I kindly request Jayashree ma'am to share her thoughts and ideas on the topic.
It's a nice presentation, Dr. Mandar. Another good thing about Dr. Mandar is his handwriting. He writes very nicely the cases. Good presentation. My thinking, since when you started, I started thinking it could be a posterior circulation stroke. The way it was presented, since patient had giddiness, vomiting, imbalance, lasting from last 3 days. So my first possibility went on, it could be a posterior circulation stroke. And as you said, with hypoglycemia, with forced glucose administration, there was improvement in the blood glucose level and his consciousness also. The unfortunate part with OHA is the glimepiride. They give very delayed hypoglycemia, it continued. And as you said, with insulin, it's easy to treat as compared to OHA. So somewhere I feel the education to the patients and the relatives to understand the symptoms of hypoglycemia. If they could have understood that 3 days back that probably it could be hypoglycemia, and simple oral glucose, oral sugar at home. So that is a very important thing for all of us, that while discharging the patients or the patients who are coming for regular follow-up for the diabetic patients and the relatives should be educated for the hypoglycemic symptom and the treatment immediate, which can be possible at home also. What can I ask him a question also? What could have been the other possibility if there is sustained hypoglycemia? Yeah. Because we had, I remember long back, somewhere in 94, 95, 96, we had a patient, same. His sugars are not improving, not improving, not improving. Old patient, known diabetic. And then we thought it could be insulinoma. And a CT abdomen was done. Thank you. Good presentation.
Dr. Mandar, very well presented. I would like to emphasize on the primary survey of all patients coming in to the emergency department. Of course, your HGT, random blood sugar, is a key vital, which would lead to an altered mental status patient having in the ER. Secondly, as Madam said, the possibility of a posterior circulation stroke was quite high. I wanted to understand if the patient had some habits like alcohol, because such patients sometimes, you would see them coming into the ER and their intake is quite heavy, and in the hospital they have this withdrawal. So there's an entity called Wernicke's encephalopathy, which has this classical triad of global confusion, ophthalmoplegia, and ataxia. So anything on that where you could get some collateral history from the family?
That it could be hypoglycemia, could be any intracranial pathologies, or any Wernicke's encephalopathy, toxin-induced encephalopathy could also be a possibility. But the relatives ruled out the possibility since they did not give any history of alcohol consumption or any tobacco consumption as well. And then since we did the HGT, immediately our mind went to hypoglycemia. So we would have liked to do a CT brain if the HGT If the HGT would have been normal, we would have liked to do a CT brain to rule out any intracranial pathology then and there itself. But since we got an HGT positive, we went with the hypoglycemia algorithm.
Right. His liver functions were fine.
Liver functions were fine, sir.
All right. He was known hypertensive also, right?
He was a known hypertensive, sir.
Okay. What medication was he taking?
He was on tablet amlodipine 10 mg, sir.
All right. Okay.
Yes.
So sometimes you have these beta blockers where
Yes,
you have these patients who overdose on beta blockers. And how was his ECG in the primary?
ECG was a normal sinus rhythm, sir.
All right. What I would want to emphasize on is sometimes hypoglycemia may just be the tip of the iceberg, and there would be many conditions that would be underlying, like you have to rule out a stroke, a CNS infection, and of course some intoxicants also. Advice should always be 24-hour hospitalization to get full examination of the patient, and to ensure that at discharge there is good drug reconciliation that is done. That is such a point which is missed quite a lot of times. So reconciliation of medicine, as Madam said, should really be done. So I think that's about it. Well done.
Yes,
Thank you.
Thank you, sir. The patient later went into sepsis. The patient's sensorium did not improve because of the prolonged hypoglycemia. Our neurologist also said that since he had this ocular phenomenon, it was indicating that the patient is having irreversible encephalopathy. The patient ultimately passed away.
So could we do any MRI on the patient while he was in the course of his illness?
No, sir, we could not. We done a CT.
To rule out any demyelinating pathology building up while he was in the...
We did not do an MRI, sir.
Once again, let me remind the residents to shoot some questions in case you guys have any doubts on the topic. They're all hypoglycemic. On that note, let me remind you.
What is cutoff for adult hypoglycemia? I don't know. Because of pediatric NS, we take a 40 milligram %. So what is the cutoff?
I'm not, is there any? 50. 70? From 70 to 55.
Thank you so much, ma'am. Thank you so much, sir, sharing your.
Just wanted to ask you, ma'am, do you think that everything has started off with one thing of the glimepiride giving a prolonged hypoglycemia, and we could not do that?
Because later on they did the imaging and everything, so they ruled out stroke or other things. Because
So-
as I said, first possibility which come to my mind is posterior circulation stroke. Unless the sugar was done when it came out to be 35 and it improved with first dextrose.
Okay.
Otherwise,
For the past 3 days when he was at home, it would have been better if we had given him
definitely,
sugars.
definitely. That's what I'm
So
telling you. They should be
that's what the-
educated properly.
Yes, so that's what I wanted to take home, that message.
So as madam has rightly pointed, I always stay for a stroke. It's always posterior circulation is your balance. Be fast. I think everyone is aware, but still I will repeat for a postgraduate. Fast is, everyone knows, facial asymmetry, disfigurement, whatever is there. Arm dift, yes for slurred speech, T for time to act. And now it is a B fast. B for balance. Madam, you are rightly pointed out because that is always missed. Posterior circulation stake, and I for any eye abnormality, any sudden loss of vision, always you suspect the posterior circulation stroke. Thank you, madam, for a wonderful session, and request Dr. Jayashree Ganikar madam to just welcome because I recognize the presence. Dr. Prasad Tushayu sir is kind enough to have been here for our CME. The next then I recognize the presence of Dr. Varshav Gore, Professor and Head of Ophthalmology. Kind enough, in spite of emergencies, like sir had come, and I request Nakul to Yes. Then I recognize the presence of Dr. Vivek Kumar sir, Professor and Head of Critical Care. I request one of the resident. You are done, Pratik? Yes. Help.
Please join me in welcoming Dr. Amal Joy, finally a postgraduate, to present a case on HELLP syndrome next. I kindly request Dr. Sushil Kumar, Head of the Department of Obstetrics and Gynecology, to preside over the case discussion to follow after the presentation. Also, Dr. Vernika Kala, Associate Consultant, HN Reliance.
Good afternoon all. The case capsule 24-year-old female G2P1L1 at 36 weeks of gestation was brought to our emergency medicine department with complaints of headache, blurring of vision and seizures. Primary survey, airway with C-spine was patent, no tongue fold, no stridor, no C-spine swelling, no tenderness. Breathing and ventilation, respiratory rate was 20 cycles per minute, depth was adequate, air entry was bilaterally present and equal, no crepitation, no rhonchi. Saturation was 94 on room air. Circulation, heart rate was 110 beats per minute, BP 170, 110 milligram mercury. Peripheral pulses were present, CRT less than 2 seconds. Disability GCS was 15 by 15, RBS 130 milligram per deciliter. Exposure, she was febrile on examination. Coming to ample history, there was no known allergies. 2 doses of TT with iron calcium tablets were taken. Past history, she's a known case of hypothyroidism, was on thyroxine tablet since 4 months. Previous history of LSES, post-datism. Coming to the events, patient had history of headache, blurring of vision since evening, and first witnessed episode of involuntary to and fro movements of bilateral upper limb and lower limb, which occurred at 8 p.m. And the episode lasts to 2 to 3 minutes, followed by acute confusion. Tongue bite also was there, and she was brought to our ED. Secondary survey, she had pallor, edema and jaundice. Abdomen was gravid uterus with fetal sounds were present. No active PV bleed. Neurological examination were within normal limits. The ED adjuncts ABG was within normal limits. Sugars were 130 milligram per deciliter. USG scan shows single live intrauterine pregnancy of 36 weeks in cephalic presentation. ECG, sinus tachycardia, urine albumin trace, CBC, RFT with electrolytes, LFT with coagulation profile, blood group, anemia workup was sent. Serology markers and dengue, malaria along with LDH was sent. Initial investigations show hemoglobin of 6.2, WBC 17,000, platelet of 16,000, INR of 1, total bilirubin of 2.2, SGOT of 335, SGPT of 180, LDH of 1,300, creatinine of 0.7. The positive findings She had blurring of vision, history of blurring of vision, headache and seizure. BP was high, tachycardic, fever, febrile, pallor, jaundice, anemia, severe thrombocytopenia, elevated liver enzymes, raised LDH. Why this case? Emphasis on the importance of approaching a patient with no preconception. The DDs in ED, we thought of eclampsia with HELLP syndrome, thrombotic thrombocytopenia purpura, autoimmune hemolytic anemia, atypical hemolytic uremic syndrome, acute fatty liver pregnancy, disseminated intravascular coagulation, antiphospholipid antibody, pulmonary viral hepatitis, and rarely macrophage activation syndrome. The common imitators of microangiopathic hemolytic anemia includes HELLP syndrome, TTP, HUS, AFLP. In that, neurological symptoms are severe with thrombotic thrombocytopenia purpura, followed by HELLP. Hypertension is more severe in HELLP. Then anemia can be more severely seen in TTP, then followed by HUS. Thrombocytopenia is more with TTP, then HELP. Liver enzymes will be more elevated in AFLP, and LDH hemolysis will be more seen with TTP and AFLP. Coagulation profile will be abnormal with AFLP. RFT will be deranged in HUS. Hypoglycemia can be seen with AFLP. Out of the DDs, atypical hemolytic uremic syndrome was ruled out because RFT was normal. Acute fatty liver pregnancy was ruled out. Initial coagulation profile was normal, and ammonia and sugars were within normal range. Disseminated intravascular coagulation was ruled out because coagulation profile was normal. Antiphospholipid antibody syndrome was ruled out as patient doesn't had any recurrent pregnancy loss history, and coagulation profile was normal. Viral parameters were normal, so fulminant viral hepatitis was ruled out. Malaria, dengue, fever profile, everything was normal, was negative, so macrophage activation syndrome was excluded. And Coombs test also came negative, so autoimmune hemolytic anemia was ruled out. And at last, eclampsia with HELLP syndrome with thrombotic thrombocytopenia purpura were initial DDs. Among the listed differentials, the presenting signs and symptoms may overlap to a significant extent. While emergent clinical decision making in ED might not change based on the etiology, but disposition and long-term therapy decision will differ based on the underlying cause. Providing the patient and family member a reliable prognosis is crucial to ED disposition, and forming a firm diagnosis can help you to quantify the outcome and present ourselves objectively. 2 pints of PCV with 6 units of RDP, random donor platelets, were transfused immediately. IV labetalol 10 mg with loading dose of MGSF4, 4 grams IV bolus followed by 5 mg each buttocks was given in the ED. Following that, prompt termination of pregnancy was done and patient was shifted to EMS ICU. Events in EMS ICU, even after supportive transfusion, patient was having persistent anemia and thrombocytopenia. Even on day 3, even after multiple transfusion, hemoglobin was 5.7, platelet was 9,000. Initial platelet was 16,000. It drops to 9,000. Total bilirubin was 2.8. SGPT-OT was coming down. LDH gone up. Initially it was 1,300. Then it elevated to 3,000. Then we given a hematology reference. As per an hematology reference opinion, we have started corticosteroid therapy, thinking that it will be a autoimmune hemolytic anemia, but Coombs test came negative. But on day 6 onwards, patient's clinical lab parameters improved. By day 10, hemoglobin became 11.2, platelet raised to 1.92, baki parameters normalized. And after 2 weeks, patient was shifted to ward. Learning points: antepartum, intrapartum, postpartum bisopenia are HELLP syndrome unless proven otherwise. Keeping that in the mind, it is necessary to rule out causes of bisopenia thoroughly. Having algorithmic approach make sure you are evaluating comprehensively and not missing out in any significant life-threatening diagnosis. HELLP syndrome is a serious complication in pregnancy, and it also increases the risk in patients with preeclampsia. Timely diagnosis and management of preeclampsia in early pregnancy will reduce the risk of convulsion episodes, multi-organ failure, and reduces fetal-maternal mortality morbidity. Thank you.
I kindly request Dr. Sushil Kumar, Head of the Department of Obstetrics and Gynecology, to share his thoughts on the topic.
It was a very good presentation, and I think treatment was also very appropriate because patient had eclampsia and you given magnesium sulfate, and second treatment for all these things is deliver the baby as fast as you can. Moment you deliver the baby, things start reversing back to normal. And here I must say that this place is quite busy in very, very serious cases with obstetrics. Everybody refers patient to us, and that's why, because last 1.5 years we had more than 150 cases of severe obstetric problems, and I thank the department. Almost out of 150 or so cases, only there have been 10 deaths, only 90% patients had survived. Now in this case, diagnosis of HELLP syndrome, people say is a rarity, but it's not a rarity. If you have, you may not have all three parameters. Hemolysis may or may not be there, but if there is other two, liver enzyme elevated and low platelet, we can still diagnose as HELLP syndrome. And there have been two classifications, Tennessee and Mississippi classification given about HELLP syndrome. In fact, this HELLP syndrome dissertation I've given to my student, and I think she has already collected 14, 15 cases, and maybe in future. But the treatment, whatever you have given is all right. I got nothing to add to the treatment because everything has been done. And congratulations to Dr. Busare and Head of Department and all the trainees who were with this patient. And I was seeing this patient off and on, but your treatment was very apt. Patient has severe hemolysis, and that was causing basically the hemoglobin to go down. And platelet, generally, I don't bother so much about platelet unless the patient is bleeding heavily. We have seen patient with 10,000 platelet and delivered normally without any bleeding. I think we put too much of stress in on transfusing the platelet, which is maybe the last thing to do. Would you like to add?
So, very good presentation, Amal. What I want to say is, as Sir rightly mentioned, HELLP is considered a very rare diagnosis, but even in my residency, I think I saw around 2 to 3 cases of HELLP syndrome. So that should always be in our mind when we are assessing any pregnant female with elevated liver enzymes or thrombocytopenia. Sir also rightly pointed out that all three parameters might not be there. So even if one parameter is there, we should make it our mind towards HELLP syndrome. And another thing, for primary survey, when a patient who's pregnant presents to us with breathing difficulty or presents to us with a saturation of 94% or post seizures, it's important that this airway management will be slightly different than the other adult airway management. You would not jump to NIV that quickly because you don't want to increase the intra-abdominal pressure. So again, HFNC is a very good method here to be basically a bridge between intubation. And other than that, very good presentation, and congratulations to you.
That was the case. Quickly, I would like to take this opportunity to welcome Dr. Philomena, Quality Head, MGM Kamoti. I request Head of the Department, Emergency Medicine, Dr. Busare, sir, to hand over a bouquet as a token of gratitude to ma'am. Welcome, ma'am. Round of applause, please. Back to the case. Any doubts, any residents? This case, I think, should not go without a doubt. It's HELLP syndrome. Absolutely. So as sir rightly said, 150 cases in the last 1.5 years, so it has become like a signature maestro case for our department. We have residents from across Bombay, from other colleges as well. They're all at the back, and like Vivek sir said, I think they are hypoglycemic. Any doubts, guys? Any doubts?
For a postgraduate, basically, here you mentioned about massive transfusion. So everyone should be aware what is, and in time, because sir is rightly said, sir, those 10% patient, if you see the time of presentation to our ER, it is more than 24 to 48 hours, or those who have been transferred from one suburban to other suburban, because it took time and they have gone into DIC and death. Otherwise, if they are in time, definitely we will take care, because sometimes it is not in our hand. So everyone, you should be aware about what is massive transfusion protocol. You saw here also, it is like if you are giving 4 points in 1 hour, 10 points over 24 hours, or if you are replacing 50% of your body volume. And definitely, how do you calculate body volume? For a post, it is 6 to 7% for the adult and 7 to 8% for the pediatric. Okay, so when you are doing, it is not half, either you are doing all and not at all, but we should have incorporate like there's TEG and all. So we are planning this year for the same. We could have evidence what we can give. It is not only PRBC, platelet, FFP, whatever, on the basis of TEG report. So that is the message for the postgraduate. Yeah. We have put it for the next year. This financial year we have put, sir. If you get, then it will be a very good for this thing. Because, sir, in few patients it was helpless. I could see in front of dying. We can't do anything, because that patient presented to you also after 24 hours of bleeding. And why they referred at the end, they thought ki they could not manage that previous LSCS and placenta accreta, placenta previa, that, and then at the end they sent. So sometimes we are helpless, but as a tertiary institute, yes, sir is doing a wonderful job for those all deliveries or LSCS which are taken place here. Thank you, sir. Yeah, thank you both of you.
You must be thinking I am asking too many questions. But this is related to our department, because baby was delivered, which was very important to deliver the baby. These are some ethical questions. Patients coming to obstetrics with a serious problems, previously how strategy can change the outcome. That is what I just want to tell, because we are there since last. So previously patient used to go to Kalamboli, and then they will assess, they will bring here. Then there might be certain sometimes ego issues. I will manage the thing. That ego issue should not be there. So it was decided to the serious critical obstetric will be done here only case. So that has also improved a lot of outcome for this baby. In fact, then last month only one similar case had come. They called me, sir, what to do? Baby ko deliver karna hai, to baby ko udhar deliver karenge, idhar deliver at night around 2 o'clock. 2 o'clock at night. So sir and everybody was in the conference call, and we decided ki let the mother do, will take care of the baby, and baby was transferred to Kalamboli, because Kalamboli we are having NICU. So this sort of thing has to be done take into consideration everybody, even at nights, and that sir, everybody, even at this seniority he is doing. So that is very remarkable things to happen in the institute. Another thing, sorry for, what about this platelet, sir, has already, so what level you generally give these RDPs, or what is in adult means?
As far as mother is concerned, if patient is not bleeding and there is no emergency cesarean required, we wait till 10,000, below 10,000 platelets. Otherwise, if you are taking for surgery or you are going to deliver, 50,000 is surgery. That's what we follow.
Because let me tell you, we have facility for both. It's like random RDP as well as SDP, single donor platelet. Most of the time, I think, as BT sir is here, professor, so we have to request. There is a little bit cost problem, but still, we have got the facility of apheresis unit. That is a wonderful thing, sir. So there is no issue for that.
Okay. We also in pediatrics also have similar episodes. We get a lot of case of ITP, which is similar to your TTP little bit.
Yeah, baby also get involved.
So we also follow same 10,000. We wait unless severe clinical bleeding is there. Then only we go for. Otherwise, wait and wait.
That's the last word. I think God is listening to Dr. Kamale. We will be having the ward within a month or two. We are going to shift this side.
Okay.
Thank you, sir.
So the only thing is, if the platelets had not improved, so you have to remember it's one spectrum. HELP is at one end, TTP is at the other end. Today they may be HELP, tomorrow they behave like TTP. If you give steroids, transiently everything comes up, then it dips again. So never delay a plasmapheresis if the patient is not improving.
Obstetrics, most of the cases, the moment you deliver within 48 hours situation, things start improving. The main treatment is the delivery. If you deliver, patient will be recovering back to normal. So we try to deliver and we give them all premature babies. That's why he's screaming.
Thank you so much, sir. Thank you so much, sir, Dr. Sushil Kumar, for taking time from his, despite of his busy schedule. Thank you, ma'am, Dr. Varnika Kala, for sharing your thoughts and ideas. Next, please join me in welcoming Dr. Abdul Harris, finally a postgraduate from the Department of Emergency Medicine, to present a case on pneumothorax. I kindly request Dr. Doki, head of the Department of Traumatology and Surgery, to preside over the case discussion to follow after the presentation. I would also like to invite Dr. Bharat Patidar, Associate Professor under Emergency Medicine, Fortis Hospital, to preside over the discussion to follow after the presentation.
Good afternoon, everyone. Myself, Dr. Harris. We had a patient, 15-year-old female, was brought with chief complaints of sudden onset breathlessness since 1 hour. This patient was triaged as red and was connected to monitors. In ER, airway was patent with no pooling of secretions, no hoarseness of voice, no stridor. In breathing, RR was 44 per minute. SpO2 was 40% on room air and 90% on 10-liter O2 by NRM. And air entry was decreased bilateral, decreased on left more than right. Crepitations were present on right lower zone, conducted sounds were present. In breathing, intervention done was, patient was started on 10-liter O2 by NRM, and we have ordered for chest X-ray and an ABG. In circulation, heart rate was 146 per minute, BP was 140/80, CRT was less than 2 seconds, heart sounds was present normal, all peripheral pulses were present normal, no engorged neck veins and warm peripheries was there. Intervention in circulation, wide bore IV access was secured, samples were collected, and patient was started on 0.9% NS. Disability, GCS was 15/15, pupils were bilateral 2 mm reacting to light, and RBS was 120 milligram per deciliter. Exposure temperature was febrile. After the primary survey, patient was reassessed, airway was still patent, breathing oxygen 15 liters through NRM, patient's SpO2 was improved to 93%, and RR was still 38 per minute. Increased work of breathing was still present. Then we did the adjuncts to the primary survey. ECG was suggestive of sinus tachycardia. ABG was done with a pH of 7.26, PO2 was 66, PCO2 was 43, bicarbonate was 18.9, lactate was 1.2, saturation was 89 with hematocrit of 40. So we have calculated the expected PCO2, which is 34, and ABG was suggestive of metabolic acidosis with additional respiratory acidosis with a PF ratio of 108. Next, what we did was we did a chest X-ray, was suggestive of left-sided pneumothorax with a right-sided lung consolidation. Then lung ultrasound was done using the blue protocol. In the left lung, there was absent lung sliding with a lung point was present, which was suggestive of an A- profile, which is suggestive of pneumothorax. And in right lung, anterior lung sliding was present. Then an anterior lung consolidation was present, which is shred sign, which was positive. The lung ultrasound showed absent lung sliding on the left side of the lung with a lung point present, and shred sign was present in the right lung. Intervention done. ICD was inserted in the left fifth intercostal space in the triangle of safety with adequate analgesia under LA. Column movement was noted, and post-procedure chest X-ray was done. Post-procedure vitals were noted. Heart rate was 110 per minute. BP was 120/70. Oxygen saturation was 100% in 4-liter O2 by NRM, and RR was reduced to 24 per minute. Post-ICD insertion, chest X-ray was done. Ample history. Patient denied any allergy. Non case of pulmonary TB on AKT. Pulmonary TB was detected 8 months back when it was started on AKT. Patient discontinued medications for 2 months. After that, there is a history of hospital admission 3 months later for fever and cough on Jan 2023. And at that time, sputum was positive for MDR TB with AKT was restarted on 9/1/24. last meal at 9 p.m. History: patient was apparently all right at 10 p.m. and went for sleep and then developed an acute onset breathlessness which was gradually progressive and worsened and was present even at rest and was brought to MGMER in an hour. No history of worsening cough or fever, no history of chest pain, syncope, palpitations, no history of fatigue, abdominal pain or vomiting. General examination: patient was conscious oriented, poorly built, mild pallor was present, no icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. GVP was not elevated and temperature was normal. Respiratory system examination was done. Upper respiratory, nose, paranasal, sinus, throat, ears were normal. Lower respiratory, trachea was central. Shape of chest was normal. Movement of respiration decreased on left side, no drooping of shoulder. On palpation, trachea was central. Movement of chest was decreased on left side and tactile vocal firmness was reduced on left side. Percussion also, resonant note was present on both sides. Cardiac and liver levels were noted. On auscultation, air entry was reduced more on left side compared to right side. Capitations were present on right, middle and lower zones and local resonance was reduced on left side. Other system examinations were normal. Investigations sent in ER, ABG, CBC, CRP, sputum RM, sputum cultures and LFT were sent in the ER. Medications given in the ER: ceftriaxone, paracetamol and pantopen emisate were given. The diagnosis was made, which is 15-year-old male with acute onset breathlessness in respiratory distress and increased work of breathing was diagnosed to have spontaneous left-sided pneumothorax as a complication secondary to multi-drug resistant pulmonary tuberculosis. Disposition: pediatric reference were given, respiratory reference was given and patient was shifted to PICU in isolation. Pneumothorax occurs when a free air enters the potential space between the parietal and visceral pleura. Primary pneumothorax occurs without clinically apparent lung disease, and a secondary pneumothorax happens in patients with underlying lung disease. And it can also be classified as closed, open or tension pneumothorax. And it has been reported that estimated incidence of spontaneous pneumothorax associated with active TB is only about 1 to 2%. These are the causes of secondary pneumothorax. It could be due to an airway disease such as COPD, asthma, cystic fibrosis. Otherwise due to an interstitial lung disease such as sarcoidosis, pulmonary fibrosis, tuberous sclerosis, or due to infections such as HIV, pneumonia and lung abscess, or due to connective tissue disease such as Marfan syndrome, Ehlers-Danlos syndrome, scleroderma or rheumatoid arthritis, or due to cancer such as primary lung disease or metastatic disease, or due to catamenial pneumothorax. When to decide whether it is a stable or an unstable pneumothorax, which is a respiratory rate less than 24 breaths per minute, no dyspnea at rest and speak in full sentences, pulse rate greater than 60 and less than 120 beats per minute, normal blood pressure for patient, room air oxygen saturation greater than 90%, absence of hemothorax. X-ray and ultrasound. Ultrasound detects pneumothorax with a reported sensitivity of 98.1 to specificity of 92%. The initial image shows a normal lung with a presence of lung sliding and seizure sign is present. The second one shows absent lung sliding with a lung point and the stratosphere sign is present. Artificial pneumothorax. Carlo Forlani developed a technique to induce pneumothorax, forcing nitrogen into the chest through a needle pleurocentesis, thus collapsing the lung in an attempt to close tuberculous cavities. Artificial pneumothorax was independently developed as a treatment in the United States for pulmonary tuberculosis, but did not gain widespread popularity until several years later, although procedure was an important part of treatment until introduction of effective antibiotics. Take-home message: utilization of ED adjuncts helps in early diagnosis and guide in the management of diseases. In patients with history of pulmonary coughs with sudden onset respiratory distress, always consider spontaneous pneumothorax, and immediate action and intervention with appropriate monitoring helps in improving the outcome.
I kindly request Doke sir to share his perspective on the case.
Yeah, good afternoon. Good presentation.
Thanks.
So basically, always keep in mind that pneumothorax will be there in underlying pathology of the disease, and especially tuberculosis. India being a country where a lot of tuberculosis, and we're getting a lot of MDR tuberculosis.
So I just wanted to know what happened later on. Did he land up with a empyema or anything, and then was VATS done?
No, sir, no need for VATS. Patient was shifted to PICU. After that, lung was expanded in 24 to 36 hours, and ICD was removed later in 12 hours after.
So just remember, people who default, they usually get these complications. So intervention is required for tuberculosis only when there is a default, and surgery or an intervention is only to manage the complications. So ideally it's a medical disease which should be treated only with the drugs.
One thing is important to here to learn is that if we are doing the blue protocol, we are utilizing the blue protocol, we are not missing we can say occult pneumothorax. Sometimes we will not able to see patient with the small pneumothorax. We will not able to see this pneumothorax on the X-ray. Particularly in the patient, if in ER, if a patient with the trauma presented to us with pneumothorax, sometimes we might miss it. Sometimes even the we are auscultating the patient right side में air entry equal मिल सकता है if it is a subtle pneumothorax. छोटा pneumothorax है, anterior pneumothorax है, we can miss it on the auscultation, we can miss it on the X-ray itself. So utilization of the focus point of care ultrasound in emergency setting is we should give it a paramount importance, particularly if we are assessing a patient with breathing difficulty. So we will not miss the things, and it is very easy to perform. If there is no lung sliding, means pleura is not attaching with the chest wall. So if there is no lung sliding, just turn on the M mode, look for the barcode sign. You in that case you will be sure the pleura is not touching the chest wall. Next, you need to look for the lung point. Then it is confirmatory that it is a pneumothorax. Alone barcode sign, alone absence of pleural sliding, it is not confirmating for the pneumothorax. You have to look for the lung point. If lung point is there and M mode barcode sign, lung sliding absent, it is 100% confirmatory for the pneumothorax. So why I'm telling you that in particularly the trauma patient, it is very important, because trauma patient you may be receiving with the low GCS. If you are doing the fast, you might get a pneumothorax. You will not go directly intubate the patient, and a simple pneumothorax will not convert into the tension pneumothorax. You will think about putting the ICD first. Okay. So my point of concern is give point of care ultrasound use in emergency, give it a paramount importance. Okay, so we won't miss the small anterior pneumothoraxes.
I'd just like to add something. Your occult pneumothorax, does it really need an intervention? That has to be clinically judged, because if his saturation and everything is maintained, clinically he is improving, I will not do anything. I have diagnosed it. With my technology, I can point out that there is a small occult pneumothorax. But does it really is significant enough that his saturation is dropping on this thing? If that is not there, I will just hold on and keep on observing. And then do a repeat one maybe after 3 or 6 hours to find out how he's progressing. Thank you.
The risk of MDR TB when you're putting an ICD to us, what is it? Just the drain also is risky?
It all depends on whether the active tuberculosis is there inside. So, and as it is, we have to take precautions, because we are living in a country where everywhere we have tuberculosis. When we travel in trains, everywhere it is there. And people don't usually take all that thing seriously. So we are at a potential risk, and as you said, you will have to have protection inside.
Yes, Vivek sir has gotten a video. We are getting it played, sir.
So this was a patient who was shifted from emergency with 2 white lungs intubated and came to ICU and crashed. So it happened to be on morning rounds. So we did the lung ultrasound and there was absent lung sliding. There was no lung point because the entire lung had collapsed. It was a tension pneumothorax. So by the time we finished, we started and we got an X-ray done, it confirmed. So this was a needle decompression done. I'll just show you the video because many of you may not have seen it. The only discrepancy is that for trauma, we do it laterally now as per the guidelines, but this was done anteriorly. One is it was a non-trauma setting, and second is I was not familiar with these guidelines. So it was done in the classical second intercostal space on the right side.
So as they play the video, I have pressure from the top to make this engaging. If not doubts, at least could you please, people from outside MGM, the other colleges, if you could share your thoughts on pneumothorax, the cases that you have seen. Vernika.
I think I know that diagnosing an occult pneumothorax will not be helpful, but knowing that there is an occult pneumothorax is important because it can increase in size. And knowing that, so that's why the USG part, definitely it's very important, so that we take the proper precautions while handling the patient. Right, or starting the oxygen therapy. That is the only thing.
Anyone else? Probably ma'am's residents can share a different perspective of the cases you have seen.
How many have put a needle so far in your life? Anyone who has put a needle? One of our colleagues from Bombay, anyone has put a needle?
Any challenges that you have faced during the procedure? Despite of my intense effort, I don't think they want to share their experience. Probably after lunch, when they have refueled for the sessions ahead, probably they can come up with doubts.
Then everybody wondered how the pneumothorax came. Then somebody found 3 prick marks here. But then the later came out, the prick marks came after this thing. So all these things are there. I mean, I think we should be fair and transparent in our work. So
I request Dr. Sanjay Doke sir to recognize our Dr. Bharat Patidar sir, who is the associate consultant at Fortis Hospital, Mulund. So by the time all this is going on for, you see, what can kill the patient. So that's why this video is for that. The tension pneumothorax. What is just a stable pneumothorax, tension pneumothorax and open pneumothorax. So any postgraduate, how do you do the dressing for open pneumothorax? Anyone can explain? Except MGM. Yes. Any postgraduate. Open pneumothorax. See, otherwise what will happen? The open will convert into closed pneumothorax or tension pneumothorax. That's why, yes, anyone? How do you do the dressing?
Sir, it is a 3-way dressing. So a rectangular or square patch of plastic can be used and it should be sticked on 3 sides, leaving one side open. So when the patient will inhale, no air will come inside, and when the patient will exhale, so the air which is inside will escape through the open space.
Yes, excellent. Okay, so good. Then in continuation, because all this is going on for the tension pneumothorax, let me you say a wide bore needle. Can any postgraduate other than MJ will tell the needle size and the color? Yeah, start.
14 or 16 gauge needle.
Yeah, starts with.
And at least 5 centimeters in
What is the color of the needle?
gray.
Because you are asking. So whether you ask, sister, you white bore needle.
14 is gray. Orange, sorry. 16 is gray.
Orange, 16 is
Gray.
right?
18 is green.
20 is
Pink.
22 is
Blue.
24 is
Yellow.
Yeah, 7, he is absolutely right. 17 is white, may not be available at all the places. Okay, thank you. So by the time it opens, so that's a tension pneumothorax. It's a very, very important, and as well as rightly mentioned, if the size of the pneumothorax, if occupies the 1/3 of your chest cavity, normally you have to just observe as a this thing. So, and previously you have seen the one of the, I think Harris has presented. So what was the treatment historically, that pleurodesis, you said pleurocentesis. I think it was pleurodesis. I think it is pleurodesis. What is our aim is like, yeah, close the cavity. So now also there are so many procedures which pleurodesis can be done. Yeah, by using sclerosant and all. That's the thing. Because tension pneumothorax for the emergency physician is the most important to diagnose and treat. We see that's why, because one of the, I think, intern in Kerala, I think they say ki it could have been a tension, one hospital to others she went, but ultimately she died because of tension pneumothorax. That was the what was the observation? What was? See, it's just a simple thing. Simple thing, diagnosing and treating for the ER is the most important.
Hypoglycemia and tension pneumothorax is magic. Immediately you will get relief, and you get a lot of more patients if you can diagnose and treat them well.
Then one more, we had a point, you have seen like triangle of safety. Can anyone going to answer what is triangle of safety? Triangle of safety, because you saw as per the new guidelines, obsolete, it is a fifth intercostal space, mid axillary line, but you must be able to identify what is that triangle of safety.
It is in the fifth intercostal space, anteriorly.
What is the triangle of safety? There should be one triangle. There are three boundaries. What are the three boundaries?
Yeah. Anteriorly,
Yes.
pectoralis major.
Okay. Okay.
Major.
Anteriorly by lateral border of pectoralis major. Yes. Yes.
Latissimus dorsi posteriorly.
Yeah. Posteriorly by lateral border of latissimus dorsa, and then inferiorly it is the imaginary line going through the diaphragm.
This is the second round of bubbling. The first was with a 20 cc syringe. Then we went in with a 50 cc syringe while the ICD was being organized. And the patient then had 2 white lungs, and her respiratory biofire from Hinduja confirmed influenza. And then she was proned and subsequently shifted to Max Nanavati for VV ECMO. So this is the way it goes. I mean, and this was done in a real emergency. I'm sorry, these are supposed to be clinical videos. This is the first time even I am seeing it. It is unedited, but please be mentally prepared that you can do, if you are convinced on the lung ultrasound that yes, there is a pneumothorax, lung point is seen, then you can decompress it.
Thank you so much for the video, sir. By sharing our experiences and insights, we just don't enrich our knowledge, but also contribute to the collective advancement of healthcare. Thank you so much, sir, for the video. Next, we have Dr. Dharma, final year postgraduate from the Department of Emergency Medicine, to present a case on the topic non-traumatic subarachnoid hemorrhage. I kindly request Dr. Vivek Kumar, Head of Critical Care MGM, to preside over the case discussion to follow after presentation. I also request Dr. Philomena ma'am, Quality Head MGM Kamote, to preside over the discussion.
afternoon, everyone. Myself, Dr. Dharmang Patel. Case capsule: 36-year-old female patient was brought to our hospital ER with complaint of headache since 8 days, vomiting since 1 day. Primary survey: airway was patent, breathing, respiratory rate 18 cycle per minute, saturation was 98% on room air, air entry bilateral equal. Circulation: blood pressure 130 by 80 millimeter of mercury, heart rate was 90 beats per minute, distal pulses are felt, visibility GCS was 15 by 15, bilaterally pupil equally reacted to lights, SGT was 120 milligram per deciliter, exposure normothermic. Ample history: allergy, no any allergy, medication not on any medication, past history nothing significant, no any history of trauma, personal history bowel, bladder, sleep and appetite was normal, no any addiction, last meal was 12 p.m. History of presenting illness: patient was apparently alright before 8 days when she had a severe headache which was insidious in onset and aggravated since 1 day. She had a history of vomiting since 1 day. Patient described this headache was worst headache of her life. Patient was brought to MGMIHS. Secondary survey: CVS, heart sound was present, respiratory RS, air entry bilateral equal, per abdomen soft and non-tender. CNS examination: patient was conscious following command, pupils bilateral equal to right, power was 5 by 5 in all limbs, no sensory involvement, meningeal sign was negative, neck rigid was absent, head-to-toe examination nothing significant. ED adjuncts: ABG was sent which was normal, ECG was sinus rhythm, SGT was 120 milligram per deciliter. Treatment received in ER: IV access secured, patient was propped up position given, monitors attached, injection paracetamol 1 gram given for pain, for headache, IV fluid started 0.9% NS. Investigations sent from the ER was CBC, electrolytes, serum creatinine, urea and CT brain. At the disposition, patient was vitally stable, planned for CT brain flare, shifted ICU after CT brain suggestive of acute subarachnoid hemorrhage. ICU treatment course: neurosurgery reference was given in ICU, intracranial pressure measures was given, patient was started on nimodipine 60 mg 4 hourly, planned for digital subtraction angiography, which was suggestive of anterior communicating artery aneurysm. Neurosurgery reference given, review given, an aneurysm in the anterior communicating artery was operated on and then clipped by neurosurgery team. Patient was shifted back to ICU. Patient experienced slurring of speech and left hemiparesis in the ICU. Bedside transcranial Doppler was done, which was suggestive of right MCA velocity is more than 400 centimeters per second, which suggestive of severe vasospasm. Patient was sent to OT. Intra-arterial vasodilator was given in the operating room. Immediately neurodeficit was resolved. Patient shifted back to ICU and then ward. Discussion. So cerebral vasospasm is defined as a focal or diffuse temporary narrowing of cerebral arterial caribal due to smooth muscle contraction within the vascular wall. Cerebral vasospasm is detected by digital subtraction angiography or other imaging study, transcranial Doppler, magnetic resonance, and computed topographic angiography, or through the direct visualization of during the neurological intervention. Cerebral vasospasm often results when the cerebral vessels are exposed to the blood in the subarachnoid space, but may also be occur after traumatic brain injury or secondary to inflammatory conditions such as meningitis, vasculitis. It may lead to decrease the blood flow and result in neurological deterioration defined as a delay cerebral ischemia. Cerebral vasospasm constitutes one major potentially treatable cause of morbidity and mortality following aneurysmal SAH. Radiographic spasm may progress to clinical vasospasm as evidenced by the neurological deterioration and eventually permanent neurological defect secondary to the infarction. Autoregulatory dysfunction, inflammation, microcirculatory failure, and spreading cortical depolarization are multiple facets of the disease. Procedures must be addressed with the multinodal treatment to achieve improved neurological outcome. Rapid identification of symptomatic vasospasm with urgent treatment is essential to prevent permanent neurological deficit. Ultimately, the symptomatic vasospasm is best managed with the hypertension control followed by the endovascular treatment with the intra-arterial spasmolytic and or balloon angioplasty. These are the risk factors of the subarachnoid hemorrhage: hypertension, smoking, excessive alcohol consumption, polycystic kidney disease, family history of subarachnoid hemorrhage, coarctation of aorta, Marfan syndrome, Ehlers-Danlos syndrome type 4, and alpha-1 antitrypsin deficiency. These are the differential diagnosis of subarachnoid hemorrhage: vascular pathology like intracranial hemorrhage, ischemic stroke, transtemic ischemic attack, arterial dissection, venous thrombosis, drug toxicity, infection like meningitis and encephalitis, intracranial tumor, intracranial hypotension, metabolic derangement, primary headache syndrome such as benign thunderclap headache, migraine, cluster headache, hypertensive disorders. So this the modified Fisher CT grading scale, which grade 1 is focal or diffuse thin SAH with no intraventricular hemorrhage. Grade 2 is a focal or diffuse thin SAH with IVH. Grade 3 is a thick SAH with no IVH. And grade 4 is a thick SAH with IVH. In this modified Fisher scale, modified Fisher 0 is no blood, thin SAH with no IVH, grade 1. 2, thin SAH plus IVH. 3, thick SAH with no IVH. And 4th is thick SAH plus IVH. So about final words, about 75% of atraumatic SAH are caused by rupture aneurysm. In about 20% of cases, cause not identified. The remaining causes are related to variety of miscellaneous conditions, including the arteriovenous malformation, symptomimetic drugs, and other less common causes. Delayed cerebral ischemia due to cerebral vasospasm is the major contributory morbidity and mortality in patients with the SCH, occur in 20 to 30% of the patient. Rapid identification of symptomatic vasospasm with urgent treatment is essential to prevent permanent neurological deficit. Thank you.
Thank you. So what if I have to ask you, what was your learning from this case?
Sir, early detection, yes, sir. The complication of subarachnoid hemorrhage is early identification and prevent the neurological deficit is the learning point from this. Use the bedside transcranial Doppler is the major point in this case. By detecting the by detecting from this severe vasospasm by the transcranial Doppler, and immediately intervention is lead to patient improve the neurological deficit and neurological outcome.
Yeah, fine. So it was a good case. I think one is in all your algorithms, whether it is a chest pain algorithm or it's a altered sensorium, you integrate your point of care ultrasound.
Yes.
I think that RCEM 2021 curriculum has also put in a lot of things, and a lot of things are coming in now. So you cannot complete your assessment without actually formally putting in the probe and just checking whether there is raised ICP and or there is a lung issue, and if it's a lung issue, it's a pneumonia or it's a ARDS, or if it's a fast positive, then so all your working at every algorithm in your textbook, just add the point of care ultrasound. And second is you should be familiar, because if this patient has come in, the first complication is a rebleed.
Yes,
it's only from day 3 that vasospasm comes in. Yes. So never harp on vasospasm before you harp on rebleed. And of course it is good that the TCD is done, and now that since you have done the TCD, so actually to say there is no vasospasm, you have to see all the windows, the transorbital, the transtemporal and the suboccipital on both the sides. Then you can say there is no vasospasm. Normally we just do the MCA, and it's good that in the MCA only you picked up, because the most common vessel to go into spasm is MCA. And the other thing is, so that last subarachnoid hemorrhage we had, who's gone to the OT today. So he came in and he had a high blood pressure and everything was there. The first question was, is he a known hypertensive? No. Second is, when did he last pass stools? He passed stools 6 days back. So he got laxative, he got enema, he got everything. He settled, he opened his eyes, his sensorium improved, the pressure came down. So the old standard teaching is subarachnoid hemorrhage in a dark room. That is how it was put in medical colleges before. And he is allowed to sleep, no noise, and he is hydrate well and pass stools. So these are very important basic things, and I think he also has a, I think a ECOM aneurysm.
Well, it's a very nice case and nicely presented. As a quality head, I can only say that any patient who comes with a severe headache has to be investigated thoroughly. And the important thing here is joint management. And this is something we always, forget when we are dealing with patients. as has been brought out earlier also. Here you have the involvement of the neurosurgeon, the surgery team, the ophthalmologist, the radiologist, everyone. If you work as a team, what we need is a quick diagnosis. A severe headache can be very distressing, and there are so many reasons. Here you brought out aneurysm, rupture, okay, vasospasm, all those kind of things. Quick investigation, quick treatment, and quick relief, and joint management. So that's a good case. Thank you.
And the second thing is that for blood pressure management, I think one of the SAH we had before this, so they're done and there was vasospasm and they went and they came out, and I think it went into vasospasm again, and then so we put in an arterial line and then manage the blood pressure. All your emergencies, your NIBP malfunctions at systolic less than 100 and systolic more than 180. So never go by that. And I think that was a young girl, 18-year-old girl who had fluctuating altered sensorium and she was going into I think 4 days we just kept her on drips with the arterial invasive blood pressure. So please put in invasive blood pressure monitoring for anybody who's outside the normal range.
Well, our hospital is also coming up as a stroke center. So we need to have all the guidelines and you need to know exactly what to do. So those kind of, protocols we set, criteria we set up, and then we check it as in audits. As a quality person, I'll tell you, we do audits and we have key performance indicators to see that things are being done correctly. It's good.
Thank you so much, ma'am, for sharing your perspective on the case from an administrative and quality point of view. Any residents? This is SCH and TCD. People giving exams in the next 6 months, probably a recent advance, LAQ. So instead of scratching your head 6 months from now, you can probably ask and get your doubts clarified and make use of this wonderful opportunity. Anybody? Otherwise, we'll move on to the next case.
I take this opportunity to thank Dr. Vivek Kumar sir, who has started this TCD. I think I had read everywhere like when in a pediatric below 2 years transcranial Doppler, anterior cerebral artery, resistive index and all. But here I saw first time TCD and the same patient had, I think Sagar, that same patient had vasospasm, they treated and you got the response. So these are the new things, upcoming fields. Thank you Dr. Vivek Kumar sir for this wonderful opportunity and workshop organized by him for the our colleagues, medicine and allied, even emergency. Yeah, thank you.
Thank you so much, sir. Thank you so much, ma'am. Next, we have a deadly emergency, acute pulmonary thromboembolism. To present this, I welcome our final year postgraduate, Dr. Aditya Ganveer. I kindly request Dr. Rakesh Tumke, Head of the Department Family Medicine, to preside the discussion to follow after the presentation. I also request Dr. Amit Panjari, our own Assistant Professor from Emergency Medicine, to preside the discussion to follow after the presentation. Over to you, Aditya.
Good afternoon. So we had a 44-year-old male who was driver by occupation. He was brought to the emergency room with alleged history of breathlessness since last 2 days. The patient was triaged as red. The patient was attached to cardiac monitors. On arrival, the airway, the patient was able to phonate and was able to talk in words and not able to complete sentences. Breathing and ventilation, he had a respiratory rate of 30 breaths per minute, a saturation of 80% on room air. He was using his accessory muscles. The trachea was central. There were no dilated neck veins. The chest rise was bilaterally symmetrical. There were normal tympanic note heard on all over the lung fields, and the air entry was bilaterally reduced. On circulation, he had a pulse of 120 beats per minute with good volume, blood pressure of 130 by 100 mmHg. All peripheral pulses were well palpable. The capillary refilling time was less than 3 seconds. The peripheries were warm to touch. S1 and S2 heart sounds were heard. There were no murmur or additional heart sounds that could be heard. On disability, he had a GCS of E4, V5, M6, which is 15 by 15. Pupils were bilaterally equal reactive to light. There were no lateralizing signs and a RBS of 150 mg per dl. Exposure, no significant abnormality was detected. Interventions that was done, the patient was given a propped up position. The IV cannula was secured at this time. He was started on supplemental oxygen via face mask at 10 liters per minute. On reassessment, there was no improvement in the saturation and there was worsening respiratory distress. He had a persistent tachypnea and there were consistently use of accessory muscles that were present. The patient was started on NIV. Post NIV, the patient was again reassessed. The saturation had picked up to 93% on 100% FiO2 on NIV. The respiratory rate had settled to 24 breaths per minute. He was achieving a tidal volume of more than 400 ml. Adjuncts that were ordered were blood gas, ECG, chest X-ray, point of care cardiac markers, and POCUS. This was the ECG, which was showing a S1 Q3 T3 pattern, which is the S wave in the lead 1, Q wave in the lead 3, and T wave inversion in the lead 3. There was a poor R wave progression, and in the precordial leads, V1 to V4, T wave inversion could be seen like a RV strain pattern. This was a chest X-ray, grossly appearing normal. The POCUS was done for this patient. Screening 2D echo, which showed a right atrial and right ventricle dilatation. The IVC was plethoric. There was no regional wall motion abnormality. There was no evidence of cardiac tamponade. The ejection fraction was around 50 to 55%. The blood gas that was done showed a pH of 7.46, PCO2 of 21, lactates of 2.7, bicarb of 19.6, respiratory alkalosis was there. A DVT scan was done which showed a presence of a deep vein thrombosis in the left lower limb. The cardiac markers that were done were negative. So summing up the history, patient had breathlessness since last 2 days, which was gradual in onset. Initially only on walking upstairs, which was NYHA grade 2. Then over a period of 2 days, it progressed to being even at rest, which was NYHA grade 4. It was not associated with chest pain, sweating, palpitation, syncope, cough or fever. There was also a history of left lower limb painful swelling 3 days back. The patient had took medications for this from outside hospital, for which details were not available. The patient, the symptoms post which then subsided. He is a known case of hypertension since last 2 years and was on tablet telmisartan for 40 mg once a day. So the diagnosis that was made was acute dyspnea under evaluation, suspecting pulmonary thromboembolism for this patient. He had acute hypoxemic respiratory failure. He had a left lower limb deep venous thrombosis, and he was a diagnosed case of hypertension. So the suspicion of pulmonary embolism was there because of the following features. The history, he had a sudden onset breathlessness, and also there was a past history of left lower limb swelling 3 days back. The clinical features he had were tachypnea, respiratory distress, hypoxia, and the chest was clear. The adjuncts which were used showed ECG was showing S1 Q3 T3 pattern with poor RV progression and RV strain pattern. The POCUS 2D echo screening showed a RA-RV dilatation. The IVC was plethoric. There was no regional wall motion abnormality. Ejection fraction was 50 to 55%. ABG showed hypoxemia, presence of type 1 respiratory failure. The DVT scan that was done showed presence of DVT in the left lower limb, and other diagnoses were also ruled out. So we had a clinical suspicion for pulmonary embolism. We applied the Wells score for this patient. The Wells score that was calculated showed 7.5 points, which was high risk. He had a positive clinical signs and symptoms for DVT. The P was #1 diagnosis in this patient, and heart rate was more than 100. Cumulatively, adding up all these three things, the Wells score that was calculated was 7.5 points, which indicated a high risk probability of P. Therefore, the patient was then underwent a CT pulmonary angiogram. The CT pulmonary angiogram showed acute pulmonary thromboembolism involving the distal half of the right pulmonary artery near complete lumen occluding. So this is the circle that is showing the contrast is not getting enhanced because of the presence of the thrombus in the pulmonary artery. The patient received anticoagulation, injection unfractionated heparin 5,000 units intravenous. Basically, there are multiple anticoagulation that could be used during the acute management. One of them is unfractionated heparin, there is low molecular weight heparin, and there is fondaparinux. The UFH could be used either as a bolus followed by IV infusion or can be given as intermittent IV boluses. Now the question is how and when to switch over from parenteral anticoagulation to oral anticoagulation, and which oral anticoagulation